Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to this special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Lisa Stromquist, and I will be your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversations, ideas, and action. So typically, we host our webinars every Wednesday at 11 a.m. Eastern. However, during this pandemic, we're offering virtual events focused on COVID-19 outside our normal time slots, in the hope that we can bring our community together to share and learn in this ever-evolving landscape. We're also working from home without our usual technology, so please bear with us if there are any technical glitches. Since we're live today, I do want to remind everyone that while we don't take questions over the line, you all have the opportunity to type questions into the question box at any time. So I will check for questions. We'll all be checking for questions throughout the session. So please don't feel like you need to wait until the end of the presentation to submit. You're free to send them in as you think of them. So we're very excited today to be partnering with Paediatric Project ECHO and the Sick Kids Learning Institute to bring this session, COVID-19 and the Care of the Child with Chronic Disease. And we'll welcome our special guest speaker, Dr. Upton Allen. Paediatric Project ECHO is a virtual community of practice that aims to connect healthcare providers to share knowledge and best practice of care for children and youth with medical complexities. So I'm really pleased to introduce our moderators for this session, Dr. Julia Orkin, a staff pediatrician at the Hospital for Sick Children and the medical director of the Complex Care Program. Julia is the chair of the Community Pediatric Committee and incoming vice president of the Complex Care section at the Canadian Pediatric Society. We also have Michelle Ho, a nurse practitioner in the Complex Care Program at Sick Kids. And Michelle also works in a community complex care satellite clinic at the Peterborough Regional Health Centre and is one of the co-leads for Project ECHO for complex care at Sick Kids. We also have a few members of the ECHO team who will help to answer your questions. So over to you, Julia and Michelle.
Great, thank you, Lisa. So thank you everyone for joining us today. We're really excited to have Dr. Allen here. It's our pleasure to introduce him as our speaker today. Dr. Allen is a professor of pediatrics at the University of Toronto. He's the chief of the Division of Infectious Diseases at Sick Kids. He's also the interim director of the Transplant and Regenerative Medicine Center at Sick Kids. Dr. Allen is a senior associate scientist in the Research Institute, and also in 2018, he was awarded the Order of Ontario. So thank you very much, Dr. Allen, for joining us today. And just a reminder to everyone, after Dr. Allen's presentation, we'll have a question and answer period.
Thank you very much. Well, first of all, let me thank you for the opportunity to meet with you virtually and to cover this important topic, COVID-19 and the care of the child with chronic disease. The slide shown on your screen is an outline of my presentation. I'll first make some introductory remarks regarding the coronavirus family. Then I'll focus on transmission-related issues. I'll make reference to the epidemic curve, and then focus in more detail on the clinical presentation and risk factors for severe disease in children, including compromised children with chronic diseases, and then end by making some remarks regarding how one might define and protect high-risk populations of patients. Now, the coronavirus family is classified into 4 subfamilies: alpha, beta, gamma, and delta coronaviruses. And then the human coronaviruses fall into 2 broad categories: the alpha coronaviruses and the beta coronaviruses. The beta viruses include SARS-CoV-1, which was responsible for the SARS outbreak in 2002-2003, and then MERS more recently, and of course, currently, SARS coronavirus 2, which is responsible for COVID-19. It's important to recognize, though, that beyond SARS-CoV-1 and 2 and MERS, we do have other human coronaviruses which provide useful information to us, as they may guide us in terms of risk factors for severe disease in children, and I'll come back to that later on. Now, you'll see many pictures of the cartoon diagrams of the coronaviruses, and my goal today is not to talk to you about the molecular biology of coronaviruses, but rather more on practical issues relating to transmission. We know is that a virus is transmitted by respiratory droplets, typically within 6 feet, and this cartoon diagram shows you that. This is very different from viruses such as measles, that is airborne, and would be ones that would be more likely to be transmitted in situations where you're further apart, significantly beyond 6 weeks, 6 feet from the individual. Now, we do know that the coronaviruses, including SARS coronavirus 2, the cause of COVID-19, may exist in the respiratory tract of asymptomatic individuals or individuals who are pre-symptomatic. Asymptomatic individuals are ones who have absolutely no symptoms, and as far as we can find out, they remain symptom-free. At least you can't detect any evidence of symptoms. The pre-symptomatic ones initially have a period of no symptoms, but then eventually become ill with symptoms. So we know that the virus is in their respiratory tract. The key is, how does it get from the respiratory tract to infect us? And so we know there's a lot that's been in the media recently about virus being present in individuals who have no symptoms and who are pre-symptomatic and potentially transmitting infection to different individuals. But the key to remember is that the virus has to leave the upper respiratory tract to get to the environment, to land on surfaces or land on an individual to result in transmission. And so the way to think about it is that the asymptomatic person requires some assistance for virus to leave the upper respiratory tract. And so be that a cough or sneeze or aerosol generating procedures, those are some of the mechanisms by which virus will leave the upper respiratory tract. But standing beside someone who is not speaking would literally be associated with zero risk, which is very different than would be the case in measles or chickenpox. We know that virus is viable for up to 72 hours after being placed on certain objects like stainless steel and plastic. This is a recent publication in the New England Journal. And virus may be viable for up to 4 hours after being placed on other surfaces such as copper, and up to a day after being placed on cardboard. And one may find viable virus for a number of hours in aerosols. It is possible to detect a virus in the air in different rooms of patients. Whether or not that results in a significant potential for transmission, we can discuss, but that's questionable. An important concept, and you've seen this slide many times, that relates to the flattening of the epidemic curve. And we see on the left here, without a concerted effort to reduce the number of cases that are occurring, one can have a steep increase in the number of cases to the point where the healthcare system is overwhelmed. So the capacity of the healthcare system is overwhelmed. So essentially what one wants to do is to try to flatten the curve out. So it might well be that the area under the curve might well be the same. Might well be that the number of individuals who get coronavirus infection remains the same, but what you're hoping is that those individuals don't get infection and present to the healthcare system within a short period of time. So in other words, healthcare system would need time to adjust. And so all the efforts in various countries over the last few months have been aimed at flattening this curve. And indeed, when you look at what has happened in mainland China, it really does appear that the major efforts to contain and mitigate spread within China have resulted in a decrease or flattening out of the epidemic curve in mainland China. So this is where one wants to go. One doesn't want to continue to see an exponential increase in cases, but you want to see a plateauing of cases and then eventually major reduction and elimination. Now, with respect to the different ways that COVID-19 might present, this cartoon gives an example where one might have symptoms that are pretty similar to a flu. Headache, for example, myalgia, lower respiratory tract symptoms, in some patients, diarrhea, and then in more severe situations, one might have septic shock, more evidence of organ failure. Indeed, one looks at the frequency with which various symptoms occur. Fever is very frequently present, fatigue, a dry cough, people lose their appetite, myalgias may be present, shortness of breath, sputum production, diarrhea and gastrointestinal disease, more frequently in children, for example, but may also be seen in adults. So the whole constellation of symptoms and signs are evolving, but it's important to recognize that upper respiratory tract symptoms such as a runny nose, while they may be present, typically what happens is that the upper respiratory tract symptoms that are associated with COVID tend to be associated in, or at least be followed in a day or two with other symptoms. In other words, the child who has a runny nose, or adult for that matter, who has a runny nose that where the symptoms disappear within a day or so, it is less likely to have COVID than the one who, after the runny nose, starts to develop other symptoms such as a sore throat or persistence of the runny nose or nasal congestion. Now, this slide is the one I don't want you to dwell on it, but I wanted to point out one thing. And these are data from Italy. It's about on the 15th of March. I wanted to show you, if you look at where the cursor is pointing, you can see that in children and younger adults, mortality is really low. And this is really important because what we've seen coming out of China and Europe and the United States and, in fact, North America so far is that severe outcomes in children seem to be unlikely compared with adults. And this is something that we obviously need to study more to get a better understanding of why is it that there appears to be significant differences between children and adults as this relates to outcome from COVID-19. This is a report from China, the initial characterization of pediatric disease, and there's this rapid fire publications that are coming out in preprints, and often it's very difficult to keep up with them. But what has happened with some of the journals is that they'll have their editorial board carefully scrutinize the preprints and provide a synopsis of the key findings from the report. And in this one, published in Pediatrics, two of the associate editors had a look at this paper. And the key points that came out were, one, that the group studied over 2,000 children with suspected or confirmed COVID-19. 13% had virologically confirmed asymptomatic infection. Among the symptomatic children, 5% had dyspnea or hypoxia. Less than 1% progressed to ARDS or multi-organ system dysfunction. Preschool age kids were more likely to have severe clinical manifestations compared with older children. Now, this is shown here where you can see on this slide, what I've done is taken their original data and just simplified it a bit for you, where the age group are shown on the left here, and then the numbers that you can see here are just percentages. I've left out the raw numbers to make the slide rather simple. I like simple slides as opposed to complicated slides. At the bottom here are the numbers. So, for example, there were 94 asymptomatic individuals, of which 7.4% were less than 1, and so on and so forth. Altogether, over 2,000, so 2,141 children were studied. Now, the key findings from this report is that if you look at the group less than 5, so up to age 5, they accounted for 40% of the overall number of cases. So 40% of the 2,141 were 5 or less. But at the same time, despite it being responsible for 40%, they accounted for 68% of critical illness and close to 60% of severe illness. And so the signal was pointing to the fact that the kids under 5, when they get COVID, were more likely to be showing severe or critical illness compared with their younger counterparts. And the various definitions were like if you had mild, this was just a respiratory tract infection without pneumonia. Moderate, you had a pneumonia. Severe, you had a pneumonia, but there was oxygen dependency. And critical, there was evidence of the need for respiratory support and multi-organ dysfunction. So the younger kids seem to be at higher risk. So now, how about if one takes this further and try to drill down a little bit and to look at what we know about the characteristics and outcomes of coronavirus infections in children in general, and the role of viral factors and the compromised state, including the immunocompromised state. And this was a report, a retrospective study published a year ago before COVID-19 by Janet England from Seattle, Janet and her colleagues. And what they showed in summary was that younger age, less than 5, underlying pulmonary disease, immunocompromising conditions, a respiratory co-pathogen, and particularly RSV co-infection were associated with an increased risk of lower disease, particularly severe lower tract disease. And indeed, if you look at this in more detail, and you looked at the respiratory co-pathogens in this particular study, RSV seems to be the one that was frequently present along with the coronaviruses, and RSV co-infected individuals were 5 times more likely to have a severe disease. And indeed, if one looks at these 4 human coronaviruses, these are non-COVID-19 related strains. These are the regular, seasonal human coronaviruses. One sees that from October through to April, this study went from 2012, 2016, one can see a seasonal cycling of the regular human coronaviruses. And so it begs the question of what will happen this coming respiratory virus season. Will we see the potential for the reemergence of COVID-19 if indeed we bring things under control during the summer? In the years to come, will we have co-circulation of the SARS coronavirus 2 strain along with these regular human coronaviruses? And what will that mean of their interaction with RSV? So these are unanswered questions, the things that we need to address moving forward. And so to guide us, we often take into account various risk factors for severe disease, and borrowing from what we know about influenza, because we just don't have enough data for COVID-19 so far. Chronic pulmonary disease, that comes out in the human coronaviruses, that study that I made reference to by Janet England and others. The current experience with China, Italy, and elsewhere in Europe, cardiovascular disease, evidence of chronic diseases, immunodeficiency status, the young child. These are all potential variables are being associated with more severe outcome in COVID-19. And finally, I'm not going to dwell on this, but just to highlight that there have been updated IPAC recommendations for using PPE for care of persons who have suspected or confirmed COVID. And so it's important for you to check that out. The key is that there's no evidence that COVID is transmitted through the airborne route. And so droplet and contact precautions remain the primary means of addressing PPE. This slide shows a summary. This was taken from Sick Kids, put together by our wonderful IPAC team, including Michelle Sines. For routine care, all that one needs is a mask. One recognizes that it's important to assess each situation to see whether or not there are any risks present that might influence one to do a bit more than just wearing a surgical mask. And so with that, I know there'll be lots of questions. I'll stop, and I'll be happy to take any questions.
Great. Thank you so much, Dr. Allen, for that great presentation. Just before we open it up to questions, we just wanted to introduce a few of our Project ECHO team members, as well as our SickKids colleagues who are joining us today as panelists and participating in the discussion. and who can answer any questions related to their area. We have Dr. Zia Bismillah, who is a complex care physician and also supporting inpatient clinical pathways, along with Dr. Jeremy Friedman, who is an associate pediatrician in chief. And we're also happy to have our members from our complex care team here today, Dr. A.L. Cohen, Dr. Catherine Diskin, Jazz Otal, a clinical pharmacist, Ashley Edwards and Kathy Netton, social worker, Erica Gibson, and Jordan Beaulieu, registered dietitians. So thank you for that great presentation, and we'll now open it up to some questions.
Excellent, thank you very much. We are thrilled with the number of questions that have come in so far, and we will do our best to get to all of them. To begin, the first question I'm going to ask will be up to you, Dr. Allen. Has this novel coronavirus had the same seasonal peaks as the other human coronavirus, and can we expect there to be improvement as the weather warms over the summer?
So that's a great question. Yes, I would expect that there will be improvement as the weather warms over the summer, but it's important to recognize that we're not 100% sure yet how the flattening of the curve is gonna, when it's gonna really start. But I would expect that things would get better as the summer starts, the warmer weather starts. What is less clear, though, is whether or not there will be the reappearance of COVID-19 during the respiratory virus season. I think there's a high probability that there will be a reappearance to some extent. It's likely that reappearance would probably be a flat curve, but one has to do everything possible to prevent it from being a highly spiked curve. We know with H1N1 that the virus doesn't suddenly magically disappear. We do expect that this virus will be around, but that it will be occurring in with a flattened curve rather than high spikes. At least that's what we want to prevent from happening. We don't want spikes to occur.
Thank you. The second question is going to go to our pharmacist, Jazz Otal. The question is, what should we be recommending our families do in terms of medications at home and being prepared for the coming future? If you're able to unmute, Jazz.
Yep, I think that's a reasonable question. I imagine that's related to just their general care and their complex medication regimens. The Canadian Pharmacists Association and the Ministry of Health has recommended to limit the dispensing of medications to a 30-day supply because they're very cognizant of potential drug shortages if people are hoarding or if there's a decrease in the supply. So I think just usual practices in ensuring that you're refilling your medications when they are due, recognizing that they may limit it to a 30-day supply to prevent any shortages down the line. In terms of over-the-counter medications, we've been getting lots of questions. There is, as everyone has seen in the media, there's no scientific evidence to suggest that ibuprofen should be limited. So I know that that's not something that we're actively recommending, but certainly if there are other alternatives that can be used, that can be considered. If there's any specific questions related to medications, I'm happy to try to answer. But in general, I would say that being vigilant on staying on top of refills and just recognizing that we have to be mindful of potential shortages moving forward.
Mm-hmm. Thank you very much. Dr. Allen, can you touch on the next question? The question is, what is the current role for some of the new pharmacological management options that have been put forward in terms of research study design? Is there any validation or trials going forward for the use in children?
So that's a great question. So the first, there are two parts to that. The first is the role of these agents, and two, the role in children. So we really don't have solid evidence to make firm recommendations that define an exclusive course of action for any of these agents. It's important to recognize that, and so in that regard, there are several clinical trials that are in progress right now across North America, in fact, Europe as well, looking at agents such as hydroxychloroquine with or without azithromycin, Calithra. There are various immunomodulators, including specific monoclonal antibodies that help to fight cytokine storming. So, for example, tocilizumab, anti-IL-6 agent to help with the cytokine storming, and anakinra, interleukin-1 receptor antagonist as well. So there are a number of various trials. The key, though, is that we and others have put together a guidance document that helps to determine how we may consider treatment for children who are not enrolled in a clinical trial. Not that the treatments recommend an exclusive course of action, but in a situation where patients are not in clinical trials, what might we consider? And so there are a number of documents of major centers across North America have come up with these documents. The trials are largely for adults, and we're working very closely with our adult colleagues to ensure that children are included in these trials.
Excellent, thank you. I have another question, Dr. Bismillah. Can you answer the role of ACE inhibitors and if we should be discontinuing that medication for patients who are currently on that for regular routine care?
Absolutely. Can you hear me?
Yes.
So I think most people know that the SARS-CoV-2 virus is, we believe, uses the ACE2 cellular receptor. And so there's some concern whether or not ACE inhibitors could actually exacerbate disease if you had the virus. But there really hasn't been, there's no conclusive data one way or the other. I think the general consensus is that patients who are on these medications should be advised to continue them just as per their standard practice and care. If those patients do contract COVID-19, then decisions are made on a case-by-case basis. And these medications obviously are much more common in the adult population. Some of our cardiac patients are on them, but for the most part, we haven't recommended stopping them. So we've been having people continue as per usual.
Excellent. There's a question about current cases at sick kids in terms of COVID positive results. Dr. Allen, do you want to answer in current status of testing here?
So the question is the current status of testing for COVID at sick kids?
Yes.
Okay, so the testing in most places in North America, at least in Canada, gives priority to individuals who are symptomatic. So that's point number one. I.e., they have symptoms that might suggest that they have COVID. Point number two is some prioritization based on the likelihood of severe disease using a framework that I showed you for influenza that shows the categories of individuals who are more likely to have severe disease if they got COVID. And so immunocompromised patient with chronic lung disease would be given priority. I should mention, though, some important considerations, and I'll just mention one. And that is we're working with our surgical colleagues at the moment to define whether or not there's a subgroup of patients who are being scheduled for surgery on an urgent basis, and whether or not knowing whether or not they have COVID influences how the operating room is set up. And so this is something that we're working very closely with our surgical, perioperative colleagues on. It's likely that, in fact, at the moment, we do have a subgroup where we are recommending testing the 24 to 48 hours before they go into their major surgery. We're not at the moment recommending testing for the kid who comes to emerge and is asymptomatic and being admitted for a fracture or something unrelated to COVID. We're looking at that very carefully. We recognize that we have to look at the supply line with respect to the availability of swabs. And I can tell you that in our setting and in most settings in Canada, it's a finite number of swabs that are available for use in the pediatric population. And so we have to balance that against more widespread testing. The other thing that I'll add, Julia, just to complete the picture, is that the test for COVID on NP swabs actually performs less satisfactorily in the asymptomatic person compared with a symptomatic person. So in the asymptomatic person, the test only has a sensitivity of 70%, probably even less than that, but no more than 70%. So one has to bear that in mind when one interprets a negative test in somebody who's asymptomatic.
Excellent, that's really helpful. The next question is relating to how should we be protecting individuals who are coming to the hospital for regular or routine outpatient care? And I think to answer this question, the first is that the hospital has taken an approach to try and minimize any in-hospital visit that is not what is deemed essential. So each and every individual physician and department will be looking at who is required in terms of upcoming appointments and if that is an essential in-person visit. Many of the appointments have been shifted to virtual care or telephone care and alternative mechanisms. Outpatient providers such as community pediatricians and family physicians are doing the same. Some are seeing patients in person with safe screening mechanisms. So that would be a phone call ahead of time, ensuring safety in terms of any febrile or other symptoms that could be consistent with coronavirus. As well, they're having triage at the door, once again, distributing masks or asking the family to go elsewhere if symptoms have occurred. I think it's very important that we continue to do so as we know that things are changing community spread. And once again, we are encouraging continued routine care in the community for things such as vaccination, newborn care, essential in-person visits to continue in a mechanism that's safe. There are guidelines that have been put forward from many different supporting institutions such as the CPS and the Ontario College of Family Physicians, for example, that share those guidelines for the community. The second question I think Dr. Allen can answer is, are there any plans to do mass testing for vulnerable groups like complex children and their caregivers? I assume that question is related to asymptomatic individuals.
So mass testing for that group. It's something that we're looking at closely. There is no immediate plan to do widespread testing of that group, but there are some patients where the testing threshold is lowered. And in fact, I'll illustrate that with the organ transplant situation where we do test donors and recipients going into transplant. And so that's one example. And so, but there are other situations where one might want to lower the threshold for testing. And so the patient who has a chronic pulmonary disease who presents with an exacerbation that cannot be clearly linked to COVID, one may consider testing on a case-by-case basis. So we haven't rolled out, no one has, a plan for a structured approach to testing the asymptomatic person, but it's something that is being looked at very carefully.
Excellent. This is a question for one of our dietitians, Jordan. Some families have had trouble with their formula and getting enough for care for their children at home. Is this something that's an issue across the board, and any recommendations on what we should be advising families?
Hi. Yeah, so it's really changing on a day-to-day basis. A few days ago, there really wasn't an issue with supply, but it was more of an issue with the wholesalers having to limit what they send out to pharmacies. And then sometimes asking if there's an alternative product, which for some of our patients, there really isn't. So I think it's really touching base with the dietitian who's taking care of them. Sometimes there may be an issue getting it in, staying in touch with families, if they have a 2-week supply left, encouraging them to touch base with the pharmacy to get some formula in. If they can't get it in, then to touch base with the dietitian to see if there maybe is an alternative product available. For instance, right now we've heard from our pharmacy even here that there's issues getting the Pure Amino A+ infant powder in, but there is alternatives to that formula. So getting in touch with your families and also getting in touch with the dietitians as well.
For Alan, is there enough evidence to support to possibly extend the RSV Synagis vaccine for at-risk NICU babies in light of the pandemic?
So the question then is the evidence to support a more prolonged RSV prophylaxis season. The evidence isn't there. I did make reference to the Janet England study, and it's something for us to think about if we do run into problems next season. For this season, I don't think that we have evidence to suggest that that's what we ought to do in Canada because of the number of kids that are being infected being lower. Next season, I think we need to look at it more carefully. But your question brings up another related question, and that is, how do we prevent RSV or any respiratory virus in a highly vulnerable population such as newborns? And that is infection control and the creation of a cocoon around them is the important principle. And so in situations where we can't, if you take the RSV analogy, in an ideal world, you want to use Synagis for the entire year, and across a large population of individuals, but that's not practical. And so we rely on creating a cocoon around those individuals that emphasizes the importance of infection control measures, such as good hand hygiene and social distancing to augment our prevention strategies.
Yeah, I think that's an excellent point and something that we're working really hard as a complex care program to support our families to understand that infection control is at the forefront of how we can be providing care and supporting them to make safe family decisions within their own environment. The next question is funny, and I don't mean to point on Dr. Allen to have to answer it, so apologies early on. Should we be washing our groceries, our fresh fruit and vegetables to prevent infection?
It's something that, I've been thinking about a lot and, interacted with a number of my colleagues across the country. And I would say that it's important to think about creating cleaner zones within the household. And so, for example, going to the supermarket, one might want to consider removing your fruits and vegetables at the front of your, as you go through your door, and leave the container at the front there. And then when you go to the kitchen area, yes, I would recommend washing the fruits and vegetables because you've been to any supermarket and you see people pick up the tomatoes and put them back because they didn't like this particular one and so forth. Bananas are not as bad, but even bananas, I recommend washing them as well because at least they have an outer peel. But still, yes, I would support washing them, but also the principle of creating a less clean zone right at the front when the package comes in, that you leave the outer container, you take the inner one in and do your washing in the kitchen.
Excellent.
Great question.
Yeah, it's a good question. The next question I'm going to ask Dr. Diskin to answer. So what is the complex care team doing to plan for important care that is currently considered non-essential that may become essential if left unattended? So for example, routine GJ tube changes or other things that children may need preventatively that may be quote unquote non-essential.
So the question is, what are we doing about care that's routine that might become essential? And I think our principle has been to work very closely with our families and to consider what is routine, what is essential, and to consider when it needs to happen. And saying that if somebody needs to come into Sick Kids, to say that Sick Kids has done everything that it can do to make sure that it's safe for you and for your family, and that we've changed certain policies. So for example, families would be used to many people, two parents coming in with children, and that's now limited to one. And if there is the possibility of using virtual care to do something, we will do that.
Excellent. This is for Dr. Bismillah. Can you answer what PPE is required for chest physio?
Sure. So for chest physio, for all care of patients, even with COVID, as you know, we're using routine droplet precautions. So that would mean a regular surgical or procedure mask and eye protection. For chest physio, if you're doing things that are going to be considered aerosolizing, so things that are going to induce coughing, certainly any nebulized medications, any suctioning, anything like that, then you would want to wear an N95 mask and treat that as an aerosol generating procedure. But in the absence of those procedures, then a medical mask and eye protection should be okay.
Excellent, thank you. This is for Dr. Allen. Are there any plans for serological testing to identify those who may be immune to the virus?
So that's a really great question. The first point, Julia, is that we do not have a clinically available adequate test to measure antibodies at the moment. You'll hear on the news that there are some tests that are being evaluated, and there's one that's made up here in Toronto, actually, but they're not quite ready for prime time. But work is being done now to develop such a test that we can measure antibodies accurately, and not just measure antibodies, but to get a better understanding of what happens with respect to antibody decay. So, for example, what happens after someone gets an infection? Let's take mononucleosis. After 3 to 4 months, your antibodies go down. Your IgG antibodies go down. In any respiratory viral infection, the same thing happens. How long does it take before the antibodies get to a level that is less likely to be protective? We're really not quite sure, and so that needs to be studied.
Mm-hmm. Thank you. I mean, this next question, I think, is something that we all are struggling with in different ways, and I'm happy for Dr. Allen to answer it first, and if anyone else would like to add something. What would you advise for healthcare workers who are in the acute care environment to keep their families and their homes as safe as possible? What should they be wearing, washing, and should they be social distancing at home?
So that's a really great question. The most important thing I would say is in the work environment, let's just take the work environment first, is to do everything to minimize the risk that you will get infected in the workplace. And so that means adhering to the PPE guidance that's recommended. It's important, though, to recognize another very, very key principle, and that is some degree of a situational awareness or, point of care risk assessment. And so you're the emergency doctor, and you are told that kid who comes in with a broken ankle, all that they need is, is for you to have a surgical mask. But the kid is screaming and yelling and doing all kinds of crazy things. Sorry, not crazy, but they're belligerent. may want to assess that situation somewhat differently and decide, well, do I need to take a different approach to the PPE that I use? So some degree of situational awareness that takes into account a point of care evaluation, I think, should be added, and something that we should always consider. With respect to the home situation, it gets rather difficult, but I know that some of my colleagues advocate for a few key things, and that is one, whether or not they should be using one pair of shoes for work, another for home, or if you use one pair of shoes, make sure that you leave it right in front of the house as opposed to walking through the house with it. Changing your clothes immediately you get home, and things like that. Recognizing that for the most part, if you were to take your laptop to work and you took it home, as you go through the front door, you probably don't want to go straight to the family room or kitchen table to open it out and start working. You may want to, leave it at the front, take it out of the, the carrying case. I even clean mine down. So there are things that one may consider doing. There's no firm policy, though. It's just understanding the principles that might guide some of the actions that you take.
Excellent. The next question is, do you know if there's any possible immune response to the regular coronavirus that individuals may have against the novel coronavirus that would allow them to be more able to fight or even prevent this?
So that's a really great question. We really don't know. We really don't know that, and that's certainly something that should be studied. But it appears, though, that even if there were antibodies from the existing human coronaviruses that provide some protection, it would appear that protection is overridden by other risk factors as you get older. So, for example, we know that older individuals are at greater risk, and so they would have had a longer lifetime exposure to the existing regular coronaviruses. So it might be that there may be some cross protection, but it's probably not of clinical significance.
Okay, that's very helpful. I just want to once again thank everyone for their questions. We're going to probably get to 2 or 3 more, and then we may do a second session just because there's so many thoughtful questions that we want to make sure we can answer on behalf of our colleagues and community partners. The next question is around home care nursing, which I know has been a huge struggle for many of our families and continues to be so in light of some of this cocoon response. And the methods that we're using to try and encourage our families to do is very similar to what we're doing in hospital, recognizing the extreme caregiver requirements we put upon families when we do not have the same in-home support, such as nursing overnight. And that initially the hope was that this would be something that came and went, but we're recognizing that it's now potentially many weeks to months of what we are now fighting with, and it's not going to be an overnight thing. And so we're struggling and worrying for our families who are at home, who are potentially not having their home care nurses coming any longer. And so we're advising to talk to their home care coordinators, ensuring, once again, that same screening mechanism that individuals are healthy when they come into the home, excellent hand washing, and identifying ways that they can have the least amount of exposure to any individual, recognizing the importance of the care provided for certain children. It's a continued conversation and an unprecedented situation, and I think the home care agencies are working extremely hard to develop policies and PPE policies that we can share once finalized. But we are having the same issues and concerns, and I see many questions along the same avenue. The next question is for Dr. Allen. Is there any research right now? The questions are for a variety of different outcomes, but around certain disease-specific outcomes. So children with type 1 diabetes, congenital heart disease, cystic fibrosis. Is there data looking at individual outcome specifics for certain disease populations?
So I'm not aware of any specific studies that have been designed to address that, take into account the importance of ensuring that one has enough sample size within each of those subgroups. But I am aware, though, that there are a number of groups that are tracking children with COVID, and the plan would be to try to see if one can have, the crystallization of any of those, risk factors. Pretty similar to what many of us have done for RSV, for example. They get a whole bunch of kids who come into a hospital, you do a retrospective study, you pull together different centers, and you see what crystallizes in terms of risk factors for severe disease.
Thank you. For the complex care population, we are working across Canada to track in real time disease and outcomes associated. So if anyone is interested or has research areas or questions, you're welcome to reach out to us as the Project ECHO team, and we can facilitate connecting you to whomever may be working on your area of interest. The next question is around homemade masks, not in the hospital, but for the general public. What would be your recommendation, Dr. Allen, about homemade PPE at this point in time?
If you'd ask anyone, like, that's myself or CDC, anyone, WHO in January, December, January would have said probably no way. But now there's more attention being directed at some sort of, I don't even want to call it a mask, but sort of a, facial covering in situations where you can't find access to a regular surgical mask. And so, for example, CDC even thinks that in some situations where masks are not available or short, even a scarf might be, considered. And so we have heard of situations where people who are in subway, transport, who feel that they can't adequately practice social distancing and they don't have a mask, that they create something that they use. So the thing about homemade masks is that one has to take into account that the regularly, manufactured masks meet a certain standard in terms of being able to protect us. And the homemade masks don't have that quality. So I wouldn't say no, though, given that there may be some selected circumstances where they may be of some benefit based on the material that they're made of. And there have been studies that have looked at this in terms of what material they've been made of, Julia. It's amazing. I sent an article around to some of my colleagues a week or two ago that showed that vacuum cleaner bags provide a good filtration mechanism. Certain types of cloths that are used in the kitchen as well. Other types don't nearly as much. So it depends on the type of material.
Excellent. Thank you. I want to thank everybody for your questions. There's some incredibly thoughtful questions that I think need to be thought through. And I think that we hopefully will have a second session. And maybe now that we do have your questions in the chat, we can actually target some of the answers to the appropriate groups who may need to answer them. Often these questions that we haven't got to yet may include bioethics, palliative care, end of life, and decision making. And maybe that's a second session that we can have looking more directly at that. So thank you everyone for attending today's session. We're really fortunate to have a platform like this at this time and have colleagues like you that we can partner with. Thank you again, Dr. Allen, for providing such an important talk, and for everyone who participated, answering questions or answering and writing into the chat. We'd like to thank Children's Healthcare Canada for this exciting collaboration. We've compiled a comprehensive list of some literature and resources related to COVID-19 and children. You will receive this in your email shortly. They'll also be posted online on the Paediatric Project ECHO website and Children's Healthcare Canada. In addition, once again, please be well, stay safe, and thank you again for your time and all your thoughtful questions. Have a wonderful day.
Thank you.
Yeah, thanks so much, everybody. I just want to thank all of our presenters and panelists. This has been very informative, with a great Q&A, and so much more to learn and talk about. Just to remind everybody, this session has been recorded and will be available for viewing in the next day or so. And I just want to take a minute to thank each and every one of you for your dedication to Canada's children, youth, and families. And these are extraordinary times, and you are extraordinary people. So thank you all for the care that you provide and the services you provide. And if anyone is interested in learning any more about Children's Healthcare Canada, you know where to find us. So thank you all very much, and have a great day.